Good afternoon, everyone, and thank you very much for inviting me. I am absolutely delighted to be here and to share just a tiny snapshot of our journey. So, really what I'm going to talk about very briefly in the next 10 minutes is the context of kind of a internationally famous cancer centre starting to host community services, then the sort of transformation journey over the last 4 years, specific improvements, clinical leadership models, new clinical leaders, new educational models, and then kind of finally to show you the evidence that is absolutely fantastic to see how that journey has, we can show the evidence that it has benefited the people of Sutton and Merton and also the staff. So the Royal Marsden is a well-known cancer centre based in 3 sites, Sutton, Merton and Kingston, and deals very much with the international research, education and care of people with cancer, from those 1-year-old till any age. And that's our mission. But in 2011, when the opportunity came for Acute Trust to host community services, particularly because the majority of our patients, 60% of our patients, come from the local catchment area, and then the rest can come nationally or internationally, we were very keen to see if working with community services, we could improve the integration of pathways for patients and their families. So we'd kind of got some experience of doing that for people with cancer, and we felt, wrongly or rightly, that there were some lessons that could be spread across for long-term conditions, for example. It doesn't apply so well to health visiting, but we did feel there were some of the lessons we'd learned in governance, quality improvement, financial security, etc., could be used across into community services. And so that's what we did, and we successfully bid at the end of March 2011. What, if you were looking at the issues facing a community service nearly 5 years ago now, what would they be and what are they now? So when I talk to the sisters and CNSs in the community, one of the things that they always raise, really and absolutely properly, is that at least in a hospital you can say the ward is full. One of the things that is very difficult for them is the demand going massively up in a very acute curve, and of course they don't have extra staff to deal with that, and they can't say no, can they? They can't say the ward is full. So there is an increasing demand on them, and of course there's an increasing demand in terms of acuity and in terms of end-of-life care. And so the challenge is very acute. The patient population, as you know, has changed. I used to talk about the acute hospital and community services, and the leaders of the community services reminded me that that's very naughty, because actually community care is very acute indeed. So I now talk about the inpatient areas and the community areas. The community nurses in Sutton and Merton had undergone loads of organisational change. And I know this is a kind of factor of the NHS that we know and love, but actually it's very destabilising and unsettling. And if you're trying to ensure continuous improvement across a linear trajectory, it's very difficult when you keep being reorganised. So we were acutely aware of that. And also of the short-term relationships, which don't help build that coherence and continuity. There are lots of issues with long shift patterns, and particularly with remote access to IT. And then we were very keen to ensure that we tried to improve the patient experience across the community services, because, as you know, they have not been reported well in London generally. But that's more in acute hospitals, to be honest, than in the community. I'm not going to go into this in detail just because of time, but one of my mentors for thinking about how to improve the experiences of patients and their families is the work of Jill Mayburn at King's, but also the work of Jocelyn Cornwell and the Point of Care Foundation. And basically what she would say, and you've probably seen this model before, of the patient experiences being a mix of the transactional, so the kind of jobs that we've got to do, and then how we relate to people. And we often get the mix of those wrong, so that we're either very efficient but not very compassionate and kind, or we're very cuddly and warm, but not very efficient. And of course, what we want to do is be in the quartile that is efficient and warm or compassionate. And to do that, we need to understand what people want. And my experience, both working with nurses in the community and across the NHS, is that they do understand that. The empathy across nursing is very, very high generally. But if we ever are worried about that, I go back to these texts from Professor Jessica Corner, who's a professor of cancer nursing, and Dr. Jocelyn Cornwall, who I've already mentioned. And it is very, very clear from the evidence that if we engage and care for our teams, then they will have more energy to care for people and families. And so that's very much what our journey has been about. We've also very much enjoyed working with community services across London, and being a very novice person in this respect, I've had enormous support, some of whom are in the room, from the Chief Nurse of London, but also the other Chief Nurses of Community Services. And I have to say, it is a wonderful team of people. So we've managed to put in lots of new models and also new posts and senior nursing posts, the 8C and 9, around leadership on the ground, clinical leadership models. And I'm not going to go through this too much in detail, but we've just, for example, employed a nurse consultant for the crisis team. And this is all about, so she is an experienced A&E nurse consultant, and she will be bringing her expertise in helping us to avoid avoidable admissions to A&E, but also to kind of bring people out of hospitals as well in a safe manner. So avoiding people going in and kind of sucking people out in a much more effective way. We've also, with the help of the Royal Marsden School and with the help of the current community nursing students and with their mentors and senior nurses, devised a bespoke programme for nurses new to the community, because there seemed to be a gap once people had qualified to then feeling comfortable in that transition to fairly autonomous practice, which is of course quite different to working in a hospital where you've kind of got different grades of staff working with you on the ward. So this programme, very much developed by people like Debbie Linden-Taylor, who's a wonderful expert we were lucky to grab for the community, is an 8-day programme looking at key clinical and professional issues, and it's been built totally for the community nurses. They all had a particular project, and they get academic credit for it through St George's University of London. So we've run 2 programmes, and the next one starts in March, and the feedback has been absolutely fantastic. I'm getting a bit of feedback, aren't I? Apologies for that. Has any of this worked? So we've invested in senior nursing colleagues. We've changed the locality model so that there's now 6 localities focused around patient hubs. We've ensured that there is clinical nurse specialists for quality and safety in those hubs. We have a Darcy fellow working on leadership and the new nurse consultant. Has it made any difference at all? So this is the key performance indicators over the last 3 years. And I think you probably can't read the small print, or you might be able to, but you can see this is for safety, quality, and patient experience. I'm just going to show you in a minute. Across, one of the things that we noted in the community services when we took them on was they had something like 180 KPIs that they had to monitor every year. A hospital has far fewer than that generally. However, monitoring all of those and reducing them somewhat in a sensible way, you can see the difference. So that's not obviously just leadership. That is done through the leadership and then empowering the nurses on the ground. So this reflects the fantastic work of the community nurses. And all this data is collected centrally, so it's pretty robust. And then if you look at, we use Meridian for our friends and family test in the community. If you look at the difference between the responses, so this is how likely are you to recommend this service to friends and family. In December 2013, on this side, the blue is the one to look at. You are extremely likely. And then you can see by the following year that it's nearly all blue. So both in safety, quality, efficiency, and patient experience, the change over 3 years has been extraordinary. And given the challenge in the community, which I have to say I'm a complete convert to the community now, I think it is the most amazing place to work. I probably should have started out there rather than ITU. It is amazing to see that. So I guess in conclusion, personally and across the teams, I think clinical leadership has made a massive difference. Yes, we have invested in the things I've listed here, but none of that would have worked without really good engagement and support for the nurses on the ground. Thank you very much for listening.
Good afternoon, everybody. When the facilitators and the event organisers asked me to stand up here and talk to you about how to move and manage integrated teams through ongoing motivational leadership, I thought, blimey, why have they asked me? I'm certainly no expert in motivational leadership, and whilst we're immensely proud of what we've achieved in Bromley Healthcare in a very short period of time, it's by no means perfect, nor without its faults or failings. So I just figured I'd talk to you today about what we've done and what we've achieved. I joined Bromley Healthcare in April 2013 as an outsider to nursing. I'm actually an accountant by background, having worked for a large accountancy firm, providing financial advice to the public sector for 12 years. And I wanted to move into a role that gave me the opportunity to make a real impact, to have some real tangible outcomes. And Bromley Healthcare has certainly given me that opportunity. So when I joined in April 2013, we had a pilot integrated community team that had been set up a couple of months earlier. And that was beginning to demonstrate on the ground the benefits of bringing together integrated working between nursing staff and therapy staff. The pilot was led by a very passionate team leader who came from a background of working in a multidisciplinary team. So following the initial evaluation of the pilot, I was challenged with restructuring our core community services from 4 district nursing teams with over 18 caseloads, 1 community physiotherapy team, 1 community occupational therapy team, and 1 community matron team, which was part of a wider long-term conditions team. And to move those into 6 multidisciplinary, locality-based integrated community teams, and to pilot social care integration and mental health integration in one of those teams at the same time, and to do it in 8 months. Now I figured straight away that as a newbie and an outsider, there was no way that I was going to achieve this on my own. The only way it was going to work was if I took all of the staff with me on the journey, some 150 plus of them. It had to come from them. It couldn't be seen to be coming from me, and it couldn't come from management. It really had to be driven by the frontline staff. And the benefits of integration were clear from the pilot project. And whilst it hadn't been running long enough to have comprehensive, robust data set that could demonstrate outcomes and savings, and to me as an accountant, that's kind of what I wanted to see before we moved this thing forward. The benefits for the patients and the staff were demonstrable every day on the ground. And we also knew that the model wasn't perfect, it wasn't right, it needed some fine-tuning. Some of the processes needed changing and the pathways needed changing, and they still do. But we knew that the way forward was clear. So the first thing that I did was I went and spoke to all my relevant service leads, got their input, their support and their buy-in, and this required a huge amount of their time and their patience with me. Being an outsider, I asked them a ton of questions, and I asked those questions time and time again, over and over again, until they were kind of bored of talking to me about it. But together we developed the model, and we developed our rollout plan and looked at what it was going to look like across the borough. And then I went out personally and met all the staff that I could, went to all the team meetings that I could, presented to them what we were planning on doing and why we were planning on doing it, getting their buy-in and their engagement. And I asked the staff for their feedback. And I had to listen to that feedback, I really had to, because I didn't know otherwise. I had to say to them, if you don't tell me, how will I know? If you don't tell me if something is going to be a real problem, then I'm going to go ahead and make the decision anyway. So unless you tell me something, you can't then say that I told you so. So come on, tell me, everyone. And they did. They really bought into that approach. I was very honest with them, open with them up front, shared the data, shared the analysis, explained why Nurse Mayo had to be moved from base Y to base X because her skills were needed over there, why Team 1 was bigger than Team 2 because that's what the data analysis had showed in terms of the need for resources. And then we worked out what the nice-to-haves were, what the real showstoppers were, and we moved forward into the rollout programme. But having said knowing what the showstoppers were, actually, it was the really small stuff that mattered. That's what mattered to staff. Some of the teams, for example, they didn't get off to the best start because we hadn't given them the support that they needed when they moved premises. So the staff were really mucking in on the ground, sorting out waste paper bins and filing cabinets and pedal stools and all that kind of stuff that I'd never imagined I'd be dealing with. But actually, that's what was really important and what really mattered to the staff on the ground to get it working. So for those teams that we didn't provide that support for properly, it kind of took the edge off the shine a little bit about what it was we were actually achieving. But what impressed me the most during all of this was the commitment of the staff to their patients and to delivering high quality care at all times, and how they kept this up during this period of change and turbulence. They worked together to make it happen. They drove it. And they had to, otherwise it would have failed. So this is just one of our teams that got Team of the Month award for the way that they'd pulled together when we were rolling out the integration. And we did it. We were 2 months late. We rolled out the teams on the 3rd of March 2014. So now all our core community services are restructured into 6 geographically based multidisciplinary teams. And that was the easy part done. We're 10 months in now, and we have to work every day to keep the momentum going and the enthusiasm going for this. One of the ways you can do that is to get some quick and early wins, to allow the staff to see the benefits of working together in this way. You can use some really high-tech tools, like a whiteboard and some columns. And this is the tool that we use to just set out who are our most complex patients, who are those that are at risk of going into hospital, who are we really worried about. Who do we need to work together as a team to make sure that they can stay at home and be cared for at home? And our team leaders are the facilitators of our weekly MDT meetings, and of course they were a bit sceptical about the whole thing. And this is a quote from Betty, who's one of our stalwart district nurse team leaders, who went into the role of a team leader for an integrated team. And she said that prior to the first multidisciplinary team meeting, I had the usual reservations about whether the whole thing might just collapse at the outset. However, our first whiteboard meeting went very well, and it became immediately apparent that this way of working had enormous benefits for patients. It was a joy to pull together clinical experience from across the professions and work together in developing care plans for our most complex patients. It's what nursing and caring for patients in the community is all about. And each week, this is what brings the teams together to make sure that they're working in a joined up and coordinated way. So some of our critical learning points from rolling these teams out is don't forget the small things. I never thought it would be my job to make sure that everybody had enough filing cabinets in the premises, but actually went and got the rest of our support services around us quickly enough and in time to support that. The team leader role really isn't easy. And actually, in some ways, those people that are slotted into those roles, from having managed their own profession, like district nurse team leaders, for example, going into a role where they're now managing different professions, they're not necessarily always initially comfortable with that. And perhaps some of the team leaders that come in new from the outside who've opted to take the challenge find it slightly easier. And we also have to bear in mind that they're trying to do this in a time where the demands and the pressures on the service are just increasing. We can't, these aren't services you can stop and pause, restructure, and then start again a week later. You have to continue to deliver the services that you're delivering whilst making these changes. Like I said, there are some quick wins, but true integration takes time, momentum, keep smiling when it all just feels too hard. And leadership at all levels is key, not just kind of management, but also all the way down. And actually, it was our physiotherapists who were the ones who were most anti the integration. They liked being a team of physiotherapists. They really felt that they would lose that connection with each other. They'd be a dispersed team of clinicians. But actually, because they've got really good leaders from within them, they've made it work. They've really stuck together. They still have their monthly meetings. And they can look at the service both across the borough in terms of ensuring consistency and quality across all the borough, but they can also look at each locality and what the needs of their localities are. So we're just over 10 months in. We've still got a long way to go. Some of the things that we're looking at is use of technology. So Jonathan was mentioning earlier EMIS. We're still building our EMIS templates for the community teams. And building the systems and the way that we allocate workloads and look at patients, and making sure that we build EMIS to support our integration. We're looking at wider integration, so our original pilot project now has a social care manager from the local authority and a community psychiatric nurse from Oxley's from within it, and every day they can see the benefit of having mental health, social and physical health all together. We're trying to develop a baseline of core skills. So irrespective of what your profession is, you can all take a blood pressure reading, you can all take temperatures, you can all do a simple wound dressing, you can all do a dementia screen. So every profession should have that core basic skills when they go out. And that's working. I caught up with our community psychiatric nurse a couple of weeks ago. And she told me how she'd gone out to see a patient and done a simple wound dressing at the same time, because she knew the community nurse was going in that afternoon, but she knew that she could do it. So it saved a visit from the community nurse having to go out because she felt that she had the skills to do that. I was also on a visit with one of our community matrons recently who was going out to do an assessment with a lady, and she took the lady's measurements because the lady needed a walking frame. And she'd learnt from the physio the kind of measurements to take, went back to base, spoke to the physio, said, oh, she's this high or whatever. And the physio went out that afternoon with the right frame for her. Otherwise, that might have been 2 visits for the physio. An ongoing leadership development. I think what we're learning is there's a real difference between managers and leaders, and it takes a core set of skills to manage a team on a day-to-day basis, but it takes a very different set of skills, a really robust, resilient personality, and someone who can keep that drive going time and time again to really lead these teams and to make sure that we get the best out of integration. Otherwise, they just become co-located services. They're not actually integrating. So this is our structure as it currently stands. We're not sure it's perfect. We're not sure it's right. Particularly if we do manage to get mental health and social care integration, this may all change. So we are kind of open to the idea that we had to start somewhere, get these teams off the ground, and it's a constantly evolving process. So I'm not sure if that's about motivational leadership, but it's how we did it. So hopefully that was helpful.